Claire, we're ready for you to begin.
Thank you. Hello, everyone, and welcome. I'm Claire Thayer, Vice President with Business Development with MCOL, and I'll be your moderator. We're so very glad you could join us. Our webinar today is Trends in Provider-Sponsored Health Plans, co-sponsored by the Health Plan Alliance. Today's discussion is facilitated by Cathy Eddy, President of Health Plan Alliance, and Dennis Bolin, Chief Marketing Officer with the Health Plan Alliance. This session will offer insights into the Alliance's perspective of shared experiences, opportunities, and challenges faced today by provider-sponsored health plans and their integrated delivery systems. Joining us in our conversation will be Michael Dudley, CEO with Centera Health Plan, and John Barrich, Vice President, Business Development with Passport Health Plan. Before we get started, we have just a couple of housekeeping items. Our speakers will be taking your questions via the chat throughout the presentation. So now, at any time, you're welcome to type in your question using the chat box in the lower left-hand corner of your screen. And just as a side note, your question will be private and is only shared with the speakers and the moderators. Other participants are unable to see your questions. If you would like to receive a copy of today's presentation, we did provide a link with your dial-in instructions. And in case you need that link again, it is here. And it's http://www.healthwebsummit.com/alliance, ALLIANCE 100516.pdf. And again, that's the same link that was included with your dial-in instructions. And lastly, if you require any other assistance, please contact the Health Web Summit office at 209-577-4888. Kathy, we're ready for you to begin.
Great. Thank you, everyone, for joining us today. I'm Cathy Eddy. I'm the President of the Health Plan Alliance and helped organize the organization 20 years ago. We have been working with provider-sponsored health plans around the country for a number of years, and the map just shows you the locations of all of our plans. The Health Plan Alliance has 46 members that are all over the country. We're in 28 states. We have about 10 million lives that are covered in the organization. So through that, we've learned a lot about what are some of the challenges and trends that provider-sponsored health plans are dealing with. I think that since the passage of the ACA, what we've found is a lot more providers are interested in the strategic value that their plans are bringing to the integrated delivery system, and they're trying to figure out more of how do they manage risk and how do they move up within the premium dollar. We've also seen a lot of growth in the last couple of years of the plans and the number of product lines that they have. Their geographic footprint has expanded, and several of them, including one of our plans on the call, are also doing back office support for other health plans around the country. We've also seen some change in ownership. There's some mergers that have taken place, joint ventures, some changes in the plans that are, some are selling off, and we've even had a couple lately that are closing down. But overall, we've just seen a big influx in the last couple of years. The other thing that I think is somewhat different with provider-owned plans recently is there's a much tighter alignment taking place now between the payers and the providers, the need to work together, not only with integrated delivery systems that have a health plan, but I think just insurers and providers in general. And then we're also going to cover some of the government oversight challenges that our plans are having in the marketplace as their product lines expand and they're getting more into government programs. The strategic value of the plans is something that's been very important to the integrated delivery systems and how they go about moving to value-based reimbursement. The two plans that are with us, I thought what would be helpful is to introduce them and let them talk about the value that their health plan has to the delivery system and how that's evolved over time. I'd like to start with Michael Dudley with Centera. They've been a plan that was started in the 80s, and so they've been a long-time member, seen a lot of different changes taking place. So Michael, I'll turn it over to you.
Thank you, Cathy, and good afternoon, everyone. I hope that everyone is in a safe location away from the storm. We are located in Virginia, southeastern Virginia, and as part of the Centera healthcare system, we do business under the name Optima Health Plan and have been in operation now for over 30 years, 32 years to be precise. One of the reasons that Centera developed a health plan in the early 1980s, different from what others did in the 80s and early 90s, was their motive was not to fill hospital beds. Rather, their motive was to be able to have a presence in the payer space so that as big for-profit nationals came in, they would not just be dictated to as providers, but as providers they would be able to actually form and shape the future in that world. That reason for being has actually played out quite well. The biggest payers that are in this market in Virginia are a Blue Cross Blue Shield plan of Anthem, and then there's not very many other of the big nationals. There is a small presence of United, Cigna, and Aetna, but because of the scope and the strength of Centera Healthcare, which includes Optima Health Plan, the system has actually done very well shaping and forming its own future rather than let it be dictated to by big for-profit national payers. One of the key things that advantages a provider system in owning a health plan is the ability to receive a premium dollar and then take full control of that premium dollar rather than let it go to a third-party carrier such as Anthem or Cigna or Aetna, wherein those organizations control the premium dollar and the profit from that premium dollar. In the provider-sponsored arrangement that exists between Centera Healthcare and its owned Optima Health Plan, there is full control of the premium dollar, and so the providers win on both the provision of the care, and then the organization in total has an opportunity to win on the premium side. I would like to emphasize that word opportunity. For the first 15 to 18 years of its existence, Centera and Optima Health Plan were always just, quote, investing in the health plan, unquote. But for the last 15 or 20 years, that investment has paid off very nicely because they have the total control. I think I'll stop there and throw it back to you, Cathy.
Great. John is with Passport, which is a plan based in Louisville, Kentucky. And John, do you want to talk about sort of how your plan's evolved and the size of it, what kind of product lines you're in, and the value it drives to the system?
Sure, happy to, Cathy. Again, John Burrich, I'm with Passport Health Plan. We're based in Louisville, Kentucky. You said that correctly, Cathy. I appreciate that. We are a statewide plan, and a lot like Centera. You know, our history is very similar. We're not quite as old as Centera. We're 20 years old. Passport was really born out of a challenge to the governor back in the 90s. The health providers got together in the Louisville, Kentucky market, and they thought they could manage the Medicaid program better than the state fee-for-service model. And the governor took them up on that challenge. And there was one managed care region in Kentucky, that was around Louisville, Kentucky, 200,000 members, Medicaid members. The rest of the state remained fee-for-service for 15, 16 more years. So Passport has a very mature model in our marketplace around Louisville, Kentucky, 200,000 Medicaid members. We have 10,000 folks in the D-SNP plan as well. We haven't entered the exchange market. We consider that. Probably happy we didn't right now. But we are looking for new models as we implement a strategic plan for 2017 and 18. I would say what's unique about Passport, again, we're a Medicaid-centric organization. We're very regional. We're around Louisville, Kentucky. We have gone statewide, but most of our members are regional. But we're very unique in that we have multiple owners. So we have sponsors, and there's 5 of them, and there's some of the larger hospital systems in the Louisville marketplace, and that includes an FQHC and primary care doctors in our marketplace. So that makes it unique, and it's a challenge too, but it makes it unique in that I think the future state model of health plans is how can you work with multiple provider types, hospitals, FQHCs, and I think we'll expand that into other providers, particularly in Medicaid, because we have to deal with social determinants, so we're going to deal more with public health. We'll deal more with housing and urban league and things like that. So I think the plan is beginning to morph quite a bit, and what provider means to us, particularly because of Medicaid and our real focus on consumer engagement and addressing social determinants. We've had a 20-year history of working directly one-on-one with providers, ranging from primary care doctors to hospital systems and specialists. We've probably implemented every incentive program known to man, ranging from capitation to P4P. We are very immature and really at the very beginnings of trying to figure out what value-based is in our marketplace, and we're doing some things to help prepare for that. We actually want to launch a program in 2017. So that's a little bit of our history, and I can talk a little bit later about where we're going. But I think what the providers really like about our model is they actively participate. We have a board of directors, but underneath that there's a partnership council. And that's a representation of a very broad cross-section of providers in our marketplace. And we're facilitators. They really call the shots. So they're involved with committees, reimbursement committees. They have quality committees. So they're really designing the programs that we help them execute. And our job is to help them execute, help them facilitate, and bring them the tools to implement the programs, monitor the programs, and report on the programs. Does that help?
Yeah, that's great. Just a couple things I wanted to touch on before we move on to growth is one of the things that we're hearing now is a lot of our integrated delivery systems and just the health plan delivery in general have taken on the aims of the triple aim. One of those is around managing the health of populations, which health plans have done for quite a while, but now you see the alignment happening with delivery systems. Also, we're finding that the systems are looking at their plans as a way to be flexible to innovate. Things like hospital at home is one of those areas and things that they can do. And then they're also looking at the way to move to a learning lab with the health plans. I'm going to turn it over to Dennis now and let him talk about what we're seeing in our plans in the way of growth.
Thank you, Cathy. The second strategic area, as Cathy mentioned, that we see among strategies that we see among health systems and their health plans is in the area of growth. There may be a number of strategies that they're pursuing to achieve growth. One is to strategically serve specific population segments in their marketplace. Another one strategy may be to protect market share on the provider side. Another strategy might be geographic expansion. And here you may see the delivery system taking the lead, expanding into new geographic markets and developing relationships with other providers in that market through ventures or partnerships or mergers or ownership. Or you may see the health plan take the lead and be the tip of the spear, if you will, in entering a new market. And through their contracting relationships, establish a beachhead in a new geographic market. You're also seeing health plans leverage their services, perhaps with other health plans or with ACOs or with other types of entities. You'll see a lot of information, consultants and others in the marketplace that suggest there has to be a minimum size for a health plan to be successful and to leverage and reach economies of scale. Within the Health Plan Alliance, to be honest, we see a broad range of sizes, from very large of over 1 million members down to health plans that have less than 20,000 members. So they can all be successful. It really depends on your ability to leverage the strengths and the relationships that you have between the delivery system, the medical group, and the health plan. And particularly if you're a smaller plan, is there a particular niche that you can fill in your marketplace? So, Michael, I wanted to ask you just a little bit. You are one of those plans that's taking both a lead in terms of geographic expansion and then also taking a look at how you can leverage the operations of your plan to gain economies of scale by providing services to other types of entities. So can you talk a little bit about the growth strategy that you have there at Optima?
Sure. Thanks, Dennis. The list of items that are on the screen before us on slide number 6, Optima Health Plan is in every one of these items with the exception of the dual population. We're not in the dual population, but we're in Medicaid, we're in Medicare, we're on the public exchanges, we're in all types of commercial business, and we are also statewide within Virginia geographically. We have not gone outside of Virginia until the last couple of years, and we're doing that more in partnership with other leading healthcare systems in their markets who are interested in creating a health plan. We're not the only ones doing this. Others are going into this space as well, and most of them are doing it purely on an administrative services proposition. At Centera Optima Health Plans, we have, as we enter into this arena, we think it's important for us to be a partner in the risk that's associated with the creation and development of a health plan. So the out of Virginia partnerships that we have created, we do have equity interest in the ventures. The example I would give you is in Alabama. We're working with Huntsville Health System in Huntsville, Alabama, and the DCH Health System in Tuscaloosa, Alabama. The state of Alabama is moving from traditional fee-for-service Medicaid into provider risk Medicaid operations. Our partnership with those two systems there is not just to provide administrative back office services for them, but actually to be a risk-bearing partner with them. So we're excited about these possibilities. There are others that we have underway, but it's a good way for a health plan to be able to grow and move beyond what might be its natural borders.
Okay. What we wanted to do next is just talk about what we see as some of the changes in ownership that are happening around the country. One of the things that's happening is there's a lot of provider consolidation, and so this is creating some opportunity for part of that consolidation or merger to bring a plan to the table and help start that up in other locations around the country or geographically. There's also some joint ventures that are taking place. There's several providers that have decided they want to get back into the plan business. Maybe they were in one and got out of it, or they want to start a plan, but it's very expensive to start one. And so often what we see happening is they may joint venture with another organization that has a health plan to either bring up a new product line. An example of that is in Florida. Health First is working to private label a health plan with Florida hospitals up in a couple of their counties in MA. There are also plans that are doing that. Select Health out of Utah is doing that in Idaho with St. Luke's and helping to market their product. So there are different examples of that where they've either started up health plans together or doing some sort of a joint venture that helps them move into that. There are often organizations that are looking at the providers and their employees as a ASO account to handle, and how can they help improve the health of their employees. Medicare Advantage is probably the line of business that we've seen the most activity in. A lot of those plans have started up either standalones in new markets where they haven't been before, or plans that haven't had that line of business have been adding it. They've also been working with organizations, as I mentioned, that want to bring up an MA plan. That one is probably the most defined population, uses a lot of services, and those are done county by county, so it's usually a smaller geographic area. We've also seen states, as Michael mentioned, that have moved into managed Medicaid, or they're doing statewide expansions, as Passport has done in the state of Kentucky. Ohio did that recently in the last couple of years, where they expanded into that statewide. And then we're also seeing states that are redefining how they're doing their state Medicaid business. They're often including long-term care. They're doing some business with the duals. And so there's a lot of that back and forth that's taking place, and expanded audiences that are included. several of the states under ACA also did the expanded Medicaid population, and that brought more lives into the system. And when somebody's doing Medicaid, they often are bringing in a lot of lives all at one time as opposed to a smaller growth of a product line like an MA. And then we're also seeing lately a few plans that have been selling where they are in an established marketplace or product line. The plan may be losing money. There may be some other challenges about what they're doing, or the provider just may decide it's not their core business. So that those plans either may be selling or closing down. We've seen that in Colorado recently, in Georgia, and then we also had another plan that notified us at the end of the year in Montana that they would be getting out of the MA business. So I think this is kind of a cycle that we've seen where we see more plans that are added, and we see some that when the business is tough, they're kind of getting out. And probably the one that's been most visible around the country is the co-ops that got in the exchange, and that was a very difficult line of business, both for the provider-owned plans as well as those, and a number of the co-ops were closing down. The next thing we want to do is talk about where there is alignment and intersection points between the payers and the providers and where they really need to work together. And we're seeing a lot more of this happening in provider-owned plans and concentrated attention to it. And this is where a lot of our programming as an organization is focused about how payers and providers are working together. The first of those areas is around governance. And here there are some different things that plans are looking at as far as who's on their board of directors. I sit on a couple of the provider-owned plans that we have in our organization, one in Albuquerque, Presbyterian, and Health First in Florida. And my involvement in those boards is to really bring an industry and a national perspective to it. We're seeing other boards adding people that have insurance background where they may not have had that before, adding expertise around that. We're also seeing boards looking at the competencies and skill levels that they have of the board members, and this is going to increase as they're being looked at to do governance assessments and competencies by the NAIC. They have a guideline now that all plans annually are going to have to file a corporate governance assessment report with them, and part of that is looking at the skill set of who sits on their board, the independence of it, and how it's structured, the subcommittees, that type of thing. The governance group is often involved in the strategic direction of the organization. They'll look at the financial impact that it has, and then they have oversight certainly for the audit and compliance functions of this. John, I worked with Passport's board recently because they've been trying to make some changes. And John, I thought you just might want to comment on sort of your board structure, how you bring the different players into it, and what type of role they play.
Happy to, Cathy. Our board, remember, we have a group of sponsors, and those are very large providers, hospital systems in the Louisville, Kentucky market. We also have outside board members. We have someone that's a technologist, an entrepreneur, and some other folks from the community involved with that board makeup. I think we're in the middle of a transformation from a board perspective. Remember, we were a regional plan only, so we were hunkered down in the Louisville, Kentucky community. We had a great brand. We had market share, 75, 80%. We had 100% before the state went managed care statewide, and then the state went all in on expansion. So the markets changed dramatically for us, and we were 16, 17 years of a non-competitive based waiver guy, and then we were thrust into this very competitive market. I have 4 competitors, very large commercials that I compete against today, and they were also required to move into a statewide model. So we were Louisville, Kentucky, one region, 200,000 members. They recompeted us. They stripped our members away from us. We grew those back, which was a great recognition of our brand and the satisfaction of the providers, a lot about the providers and the members. We grew statewide. I'm not sure that's the best thing for a plan like us. So that's where we are today. So from a board perspective, we've got some real tough questions to address. One is if you know Kentucky, there's 2 factions in Kentucky. There's this Big Blue, which is University of Kentucky, then there's University of Louisville, which is red. And the red dot's very small. The Big Blues are very big across the rest of the state. So we're known as a Louisville-centric organization, and we need to probably address that. Given we're statewide now, so how we think about the board and we're in that process right now of talking to some other entities that are not in the Louisville, Kentucky market. We think that would help us on a lot of dimensions, and we think that's very thoughtful, and we have to. That will probably extend down to the Partnership Council, which is really the governing organization of Passport, which is very unique. So I think that's where we're at today. We're also going through some challenges on what do we have to grow. I was at a previous conference with Dennis, and I was sort of a guy on the other side saying, I don't really know if we have to do geographic expansion. I don't know if we really need 2 million members. We have 300,000. I think our opportunity and our right now, because we don't have any intentions of moving outside of Kentucky at this point in time. We'll do it in a different way. I'll comment that in just a second. Is we got to manage those 300,000 members a heck of a lot better, and to do that, we got to engage our provider partners a heck of a lot better than we are today. And what's unique about being a provider-sponsored, provider-owned plan is providers love you, but they also expect a heck of a lot more from you, and that puts a lot of pressure on the plan to provide new tools, new analytic capabilities. They're really looking for us to be the air traffic controller, the logistical person that helps us help them manage the members. And they also want us to expand and bring more information about that member to them rather than just plain medical information. So there's a lot more integration, I think, that will be required. And I think we had a presentation a while back in Chicago, and the CEO from AdMed said this is a systems integration job, and I really agree with that because this is very fractured. The more we focus on integrating the plan with the provider community and expanding the provider community, and then I think the other lever, third leg in the stool, is engaging the consumer and bringing them into the model as well. Just the plan provider I don't think is enough. You have to bring the consumer into it. So that's sort of the track we're on. We're trying to morph our board and the plan and the providers. This is a big transformation job to address that. Now we are thinking about growth, a lot like Centera and other states, but we've done that through a partnership with Evolent. Earlier this year, we put together a partnership with Evolent. Evolent is a national organization. They focus on provider-sponsored plans only and value-based only, and we're working with them, and we are sort of the Medicaid subject matter experts and helping them Medicaidize their solution, and their go-to-market strategy is to bring that to other provider-sponsored plans that want to get in this business. And so I think what happens in this market, a lot of people underestimate the needs and the work a plan has to do to support a provider-sponsored model. And that's sort of the track we're on as far as a little diversification and growth outside of Kentucky. Does that help, Cathy?
Yeah, that's helpful. I think one of the other aspects, and this one actually was one that Jim Hinton from Presbyterian emphasized the importance of, is culture, that you have to have a shared culture across all of your entities in an integrated system, because if you're still in silos, you're going to be tugging at each other. And that some of the language that you use is really important. And if you start taking sides or using we and they, that sort of puts you into those silos. We're also seeing that culture is very important around the alignment and where you might have competing priorities, where you're spending your emphasis. And also as organizations are putting together and how they're talking about who they interface with, it's often interesting because if you're talking to the delivery side, they're patients. If you're talking to the health plan, they're members. But when it comes down to it, all of them are customers and what you're dealing with. So even just the words that are being used sort of buckets people in where they're put together. The common experiences and goals and margins for the system, that seems to align a lot of the providers along with their provider owners and those that they're working with. But this is an area that I think we're seeing a lot more time and attention being paid to. And Michael, I just thought maybe you could comment on how do you get that culture in place where everybody's sort of working together, and are there certain things that you've found that have been more helpful than others to achieve that?
Well, as in all things, culture trumps strategy every time, but culture is always changing. It's never staying the same, and once you think you've arrived, if you sit back and say, I've arrived, the culture will change again, and you've got to move on again. Some of the things that we can do to help, though, align ourselves with the health plan and the hospitals and the physicians is making sure that our goals are consistent. They may not be identical, but they need to be very consistent. If there's a growth goal at the health plan, it's very important for the medical group or the medical community, whatever your situation is to have some buy-in to that goal. And one of the ways, obviously, to get the buy-in is for there to be some sort of shared financial arrangement that the providers, whether they're the physician community or the hospitals with which you work, to have an opportunity to share in the margin that will be created if there is growth, and you want that growth to be profitable growth, not just growth for the sake of growth, but with profitable growth, and then have a clear and easy to communicate way to share profits back to the hospital owner, if it's a health system, and to some of the physicians, so that it is clear and easy to understand. Then that's one way to get alignment around goals. And when you get alignment around goals, then cultural alignment begins to form as well. That's been our experience here, and but I'll be the first to admit that we have not arrived there yet, mostly because nobody knows what there is.
The third point of intersection that we observe between health plans, health systems, and their medical groups is around the customer experience. We hear a lot said these days around the retail market space, that the industry is shifting to a retail model. But what does that really mean? Perhaps the best definition that I've heard is, how easy are we to do business with? And if you're working in an integrated system with the delivery system, the medical group, and the health plan, working together, you have the opportunity to create a seamless, coherent experience for the member that the competition is not able to match you on in the marketplace. And so this focus on working collectively together to create a customer experience is receiving a lot of attention. You're seeing enterprise-wide customer experience officers being identified who are coordinating the effort as customers flow between and across different parts of the organization. One statement that I heard from a CEO recently, I think kind of brings this home, when he said, until we realize that the patient and the member, when they're interacting with us, is the same person, we will always treat them in a fragmented way. And so how can health systems and health plans and medical groups are thinking through how they're sharing information about the consumer with one another and how they're creating a seamless consumer experience. So there's a lot of work being done around quality ratings, the essential part of working together with particularly the medical groups on CAPS and STAR, and then the identification of touch points. And John, that's where I wanted to turn to you. If you could briefly just talk about some of the initiatives that you have there around Passport in terms of identifying the customer journey and the touch points that you've identified within the health plan and the partners that you work with, and how you're trying to streamline that.
I'd be happy to, Dennis. I think this is probably the number one strategic opportunity we're focused on today is consumer engagement. Again, a lot like other provider-owned, provider-sponsored plans, that's a well-worn road between the relationship between the provider and the plan, and I think we ignored the consumer, the customer, a little bit. And I think, Dennis, I agree that the customer experience is important, but I think the first thing you have to do is understand who the customer is, and that's critical. We're doing a lot of work today. We've engaged KBM Wonderland. They have some data we use to understand the engageability and influenceability of folks, which I think is very critical. How they want to be engaged and how they can be influenced is pretty critical. And then I think it's really important to segment your population. As an example, I'll give you a good example. In Kentucky, our governor has put forth a waiver, and part of that is a job requirement in Kentucky, and it's probably going to be more focused on the expansion population that has grown dramatically in Kentucky, and it's really not a sustainable model, affordable model. So that segment of the population the care model is different, right? The care model is really of the expansion members we have today, which of those members are currently employed that might want to seek a better job, a higher paying job. We have many unskilled jobs unfulfilled in our marketplace. Which segment of those members are looking for a job and need basic skills to get a job, and which of those members need help and encouragement to get a job. That's quite a different segment than someone that has diabetes or the segment that has other chronically ill folks. So I think it's real important. We're trying to get very consumer-centric and start with the consumer first and then build out the care plan from there. I think what we've done in the past, we usually had program of the month. This month we're going to focus on asthma, next month on obesity, next month on heart disease. So we sort of flip that model and say, can we start with the consumer, understand their needs, and understand what's available to help them. That's sort of interventions available from a local perspective, and I think these are all local custom jobs. In Louisville, Kentucky, we're very blessed with many organizations that will help someone from a very broad dimension, not just the medical side, but the social determinant side, the financial side. Far eastern Kentucky, it's a totally different model. We don't have those resources. So we got to be very agile in that. So I'd say, Dennis, it's pretty critical, that third leg of the stool we've forgotten. We had the provider plan leg. We've had the plan leg. We forgot the consumer leg, the customer leg, and we're really focusing on that today. And I think that's really going to pay off. And that's quite frankly what the providers want from us. If you talk to a provider, a hospital system CEO, or C-level staff, or a doctor in a large practice, they didn't have this in school, consumer engagement. They don't understand what it is. They know they need it. And again, I think it's part of the transformation of the plan is what is our future state role. And I think this is one critical role that we need to address, and we need to supply and support our provider partners. And I think that'll make a big difference.
Dennis, may I?
Yeah, go ahead.
Can you go back? I just would like to make a comment as well. This is Michael Dudley. I endorse completely everything that we've just heard. Our own pathway on this trip is we started many years ago using the mantra easy to do business with, and it has served us well, but we've gotten to a point where we need to take it to the next level up. And so what we've been working on over the last 12 to 18 months is identifying, quote, pain points, unquote, within the system. And pain points, not just the pain points that members have with the health plan, but pain points that our members have as patients in the delivery system. Some others are using the terminology hassle mapping. Whether it's a hassle map or an identification of pain points, it's kind of the same thing. What we're trying to do is identify the things that really bother and bug our members or the doctor's patients. And then, because the health plan is so tightly aligned and connected with the delivery system, a health plan that is aligned with the delivery system like we are, it's much easier for us to work across boundaries and solve those pain points or the hassles that are out there. One example that we're working on, or soon will be, is the whole process of scheduling an appointment. And that's a real pain point for lots of people. Number one, a lot of them can't even get a phone call to be answered when they call the doctor's office. Or if they are lucky enough to get it answered, it is weeks, if not months, before they can get an appointment. We're working on how to solve that pain point, not just by going to the doctors and saying, you got to solve this, but by working together as a health plan with physician practices of what can we do to make this process much more convenient than it is. That's just one example of the kinds of things that a provider-sponsored or provider-aligned health plan can do that some of the big for-profit health plans would never be able to do. Thanks, Dennis.
Thank you, Michael, because you're absolutely right. What we're seeing is that can be a strong differentiator in the marketplace that cannot be duplicated. And consumers are asking for it and respond to it. Absolutely. The fourth point of intersection that we observe between the health systems and health plans and the provider groups is in the area of contracting. These are some touchy issues that come up when you begin to talk about contracting. For example, do you have exclusivity? Does your system owner contract with all payers, or do they contract only with you? Does your health plan contract with all providers, or do they contract only with their own provider system? Those are on the edges. There's a lot in between on that, on the development of different tiers and networks. That's just one example in the area of exclusivity around contracting. So Michael, if I could turn it over to you and maybe have you walk us through the strategy that you're pursuing with Sentara Quality Care Network, because I think you're touching on a number of these bullet points that we have here on this page.
Sure. The Sentara Quality Care Network that has been developed in Virginia is a clinically integrated network. So if I say Sequin, you can just think in your own market of whatever CIN or ACO you may have there, and that's what I'm talking about. The health plan, Optima Health Plan, working with Sentara, developed this clinically integrated network, or Sentara Quality Care Network, Sequin, and we have begun to be able to demonstrate to our customers, meaning the employer paying customer, that for the employees of that employer group who is receiving their care from Sequin-based providers, that care generally is significantly less on a total cost of care per member per month, and the quality is higher. And we now have data that will support that assertion. Over the past 3 years we've been working on this, and we can very clearly now demonstrate to customers in our marketplace that if their employees select Optima Health, and within the Optima Health broad network, if they select a Sequin primary care doctor who uses Sequin specialty doctors, who uses Sequin related hospitals, we can pretty much guarantee that they will have anywhere from an 8 to a 12% reduction in their total cost of care, and we can also show them that based on quality metrics, that the care that they received is of higher quality, as measured in things like diabetic testing that is performed, and even getting into some outcome measurements is the next generation we're going to. So what we have not done to this point is taken that quality care network, high-performing network, and offered it on an exclusive basis in a narrow network. We may do that over the next few years, but to the extent that our marketplace still desires to have a broad network of options from which employees can select, we will embed the high-performing quality network and on a tiered basis give some advantage to employees who select that high-performing network that is within a tiered network of systems. So I think that that's what you're referring to, Dennis.
I am, Michael. Thank you. Let me take the opportunity to remind everyone that you can submit a question through the chat function. Type your question in on the lower left-hand side of your screen, and we'll see it and raise it. So we have had a question come in, Michael, that I want to direct to you because it's around those pain points or those hassle points that you mentioned. The questioner is asking if you have any other examples of pain points that you're addressing, maybe through benefit design or coverage options. So for example, making it easier for people to communicate with you and to engage with physicians through telehealth, or different treatment options like healthcare at home, which Cathy mentioned. Are there other pain points, or do you have a couple of other examples of pain points or hassle points that you're addressing from both a programmatic and maybe a health benefits strategy?
Yeah, thank you, Dennis, and thank you for the person who submitted the question. I'll start by the benefit design perspective and then come to the operational perspective. From the benefit design perspective, other than beginning to provide lower co-payments to individuals who select the high-performing network, we have really not been able to do very much yet in regard to benefit design. We are looking very carefully at value-based benefit design, which we think probably in the next 24 to 36 months, we will have a benefit design that will actually reduce co-payments and co-insurances if a person selects to a particular course of therapy for diabetic treatment or chronic care of one sort or another, and we will remove some of the barriers that are in place now that prevent people from staying on their preventive medications and the like. The obvious easy example is for diabetics who are supposed to be taking certain drugs. Sometimes they don't take them because they can't afford the co-payment or the co-insurance. I think it will not be long before we will have a benefit design that will eliminate for a person who is diagnosed with diabetes, we will begin to eliminate some of those co-payments and co-insurances so that we remove the barrier and eliminate the pain point so that our member who is a diabetic patient can no longer use that as a reason not to take those medications. I cannot tell you today that we're already doing that. I know it's being done around the country, but we have no experience with it. Some of the other pain points that are going to be there that will help in these benefit designs are embedded in the question, telehealth and digital tools that people can use to have home monitoring of vital signs and other statistics. I think there's going to be an explosion of those kind of applications that are on smartphones that will help our members take better care of themselves, and we, the health plan, will encourage that by providing those tools with minimal, if any, additional charge beyond the premium payment. So all of those things are on our list. As it relates to other pain points that have to do with delivery of care, I mentioned scheduling. We may also be looking at the prioritization of accessible appointments. And if a person is a member of our plan and they are willing to use our high-performing network, then shouldn't that person get a priority when going to schedule the appointment and have appointment accessibility to them maybe at a higher level than some other patients. So there are those sorts of things that we're looking at. Thank you.
In regard to a couple of the other questions, we are going to address medical management shortly, so I'll just sort of defer that one. And then Mark asked a question, and I think this one probably maybe is to you more, Michael, is do the provider sponsors provide you the own plan with any type of pricing or contract reimbursement rate or market advantage in the rate that you get as the plan?
Yes, thanks for that question, Mark. The way that we have done business here at Centera between the owner hospitals of Centera and the owned health plan by Centera, the Optima Health Plan, is that we virtually have eliminated all of the bickering and the arguing and the wasted time between us and them by an arrangement that we call market-based pricing. And what I say to my colleagues in the hospitals is you go and have all your fights with the dominant health plan in our marketplace, and whatever it is you can get with them, then let's just have the Optima health plan have a similar, it may be identical, but it could be a point or two above, a point or two below, but have a similar reimbursement schedule for the owned health plan as what they can get from the other market-leading health plan. And that has been an approach that has been in place now for over 15 years, and it has almost totally eliminated the fighting and the hassling and the bickering that was going on between the family before that.
Great. Thank you, Michael. I'm just going to quickly touch on risk management. The point that I would make here is the importance of the health plan, the health system, and the provider owner, again, collaborating, particularly in the areas of risk scoring that provide the foundation for the risk adjustment payments, particularly under the ACA. And so what we're seeing more and more is a collaborative effort of the health plan and the delivery system going out to the physician groups to work with them on coding education, the risk assessments, and the work there that has to be done. So again, a coordinated effort in order to really make an impact on risk management. Cathy?
Yeah, the next area of where providers and payers are working more closely together is around clinical integration. I think here to Jana's question about that and others, this is where you see a lot of formation of accountable care organizations and clinically integrated networks. Mike described the one that they had put together earlier. The quality metrics have a huge financial impact on a lot of these organizations, and so you see them having to work in tandem to really kind of get the quality metrics in stars and other types of areas, as well as the risk adjustment. And then we're seeing a lot more integration within the care management structure and how those are being put together. And I just thought that, Michael, if you could describe what you have been doing around care management integration within your system, and then a follow-up with that of John talking about just sort of some of the leveraging of community resources and integrating them into the care pattern as well. So, Michael?
Thanks again, Cathy, and I see our time is brief, so I'll try to be very brief. What we have done on care management is we have care management skill sets and functionality at the health plan. We've also begun to embed the same sort of capability within the CIN of Centera's Quality Care Network. But we have done so with an underlying principle that we do not want to duplicate anything. To the extent that resources are devoted to the CIN, then the health plan backs off. But if the CIN needs additional resources that are available to health plan, then we come in and we work hand in hand together on that.
And John, just briefly, what are you doing to include the social resources that are available in the community and the whole care integration?
Yeah, I think this sort of goes back to your point, Cathy. We sort of have a translation problem between the plan and provider systems. We work with a lot of provider systems, and they want us to work with their SIN, and I ask them, what does that mean? And sometimes I get a good definition, and it's usually around clinical integrated network, and I say, well, that's not what I want. I want a community integrated network. Just a clinically integrated network is really not going to address the problems that we need to address to really improve the well-being of the person, because it expands way beyond just the medical needs of a person, the physical health needs. So I think that's, hallmark is getting, agreement on what that definition is and what that need is between a plan, particularly one that's focused on vulnerable population, Medicaid population. But I would suggest that would apply to any population, commercial or not. And the design of that is not easy. These are all custom jobs. When I say it's a community-based model, it's a community-based integrated network, it is. And they are very localized. So trying to do one side, we were at one engagement, and a large system said we have 80% of the SIN is leverageable from market to market. And we challenged them on that, and it ended up being no. 10% was leverageable. 90% had to be custom, because you really had to understand what was available in your community to address the needs of your particular consumers.
Great, thanks. The next one that is, I think, a lot of time is being spent on now is the whole informatics and analytics. This is an area that has been built up within the health plan to be used, but now that the delivery system is getting more a need for analytics, there is this coordination that needs to take place around what's being shared, how do you partner around that, what's the interpretation of some of the information and how that works. And there's some, I think, workforce challenges too, just getting the expertise to be able to do the analytics that are needed. I think one of the organizations that's really kind of been in this for a long time and has taken it farther has been Centera in their analytics. And Michael, if you could just sort of briefly comment on how you approach this idea of getting the right tools and that in place without duplication within a system.
Yeah, thanks, Cathy. We have been in it for quite some time, and the skill set was developed, frankly, at the health plan, and it was done well enough that our provider side said, gee, we'd like that. So they basically confiscated everything we had some years ago and took it over to the health system. And then a few years later, I said, whoa, wait a minute, we're not getting what we need. We want it back. And so we took a little of it back, and then we started duplicating stuff, and that wasn't good. So a couple of years ago, we sat down and said, okay, we all want to know who the high-performing doctors are. We all want to know who the high-performing hospitals are. We all want to know what kind of treatment regimen works better than another. We need a clinical information system that will help answer those kinds of questions, and none of us can afford to do it on our own twice. So we said, okay, we're going to do it, and we're going to do it on an enterprise-wide level basis. And so we've invested nearly $20 million now in updating the clinical informatics that we will have that will assist us at the health plan and use those same tools that will assist the hospitals and the medical group in their office-based practices determine what is happening from a clinical perspective throughout the organization. And again, a guiding principle is thou shalt not duplicate any of this investment, but make one investment that works for every component of the healthcare enterprise.
Great, thanks. And then the last area of intersection that we're seeing a lot of more work in tandem is around the technology assessment and IT infrastructure. The capital budgets of systems are looking at this and how to leverage those dollars effectively. When new technology is coming out, what is the value of that? Both from a should we pay for it plan standpoint, and then is this the type of technology that we need or adds value to the patient care? There's a lot more assessment being done on just what type of software is needed and the infrastructure and how to share some of that going forward. There was a question also from Mark saying regarding the technology side, is there anyone seeing a breakout technology providing strategic or market advantage? Michael, anything that you're seeing on your side with that?
On technology that's providing a breakout, strategic, or market advantage, not just yet, but a lot of these applications that are on the cusp of being ready to implement may help us make some difference. If we do have one, it would be an application called Livongo that we are using to help diabetics manage their care and their disease in a very, very minute-by-minute sort of basis if they want. And it's an application that is not developed here inside. There's so much development going on outside that we're always keeping our eyes open for these kind of applications that will help promote member/patient engagement, help them be more healthy, and therefore help reduce the cost. So there's an example.
Okay, great. And then the last slide, we just wanted to make the point that government oversight is becoming increasingly onerous, I think, for a lot of plans. The Accountable Care Act added a lot of that with the Medicaid expansion, the Medicaid rule that's coming down, the exchanges. Certainly you see it with the Medicare Advantage plans and what they have to deal with. And then there's a lot of other things. So I just thought as a wrap-up we could ask the two plans on there just to talk about some of the challenges they're seeing for themselves and their delivery system in this whole government oversight aspect of it, and any other kind of final comments they want to make. So Michael, do you want to start, and then we'll have John finish up?
I'll go brief because, John, I've taken way too much time, and I apologize. Let me just say that the Affordable Care Act has added several $million to our administrative expenses, and quite frankly, I'm not sure that we've seen a whole lot of value added at the member level, and it's very unfortunate, and I don't mean that to be a knock on the Affordable Care Act in general, but that is one of the downsides of it. I'll leave it at that. John?
Yeah, I concur, Michael, that it's a challenge for us. But I think the other issue we face is, the government sort of said we're going to, trust the stewardship of this program to, managed care entities, entrepreneurs to make it better. But, the regulations are so daunting, you can't be an entrepreneur and make it better. So there's got to be some common ground. And I think the challenge we have is in some way we've got to get the regulators in the room with us. And rather than them dictating what this should be, because I don't think they may not know what this should be, we need to work together and collaborate on what it could be and come up with new models. And we're not quite there yet. There's, I think the market in general, we got a big trust barrier we got to deal with. It's the consumers don't trust the health plans don't trust the providers vice versa, and then the government. And if we don't knock down the trust barrier between us and actually collaborate, it's going to be a challenge, a big challenge.
Great. Well, Claire, I'll turn it over to you to wrap up.
Okay, thank you. Wow, great discussion, everybody. Okay, well, we'd like to take this opportunity to thank all of our speakers, the Health Plan Alliance, and all the participants for joining us today. As mentioned at the beginning, we will be sending a feedback follow-up form to all the participants via email before the close of business today, and would love to receive any feedback you wish to share about today's event. This is also another great opportunity to submit questions for the speakers. If you haven't already done so, we encourage you to join our LinkedIn group on the web, where you can also post questions and start discussions and suggest topics for future events as well. This now concludes our webinar.